welcome. You're clocked in, the fluorescent lights are humming, and you've got that steady, organized chaos of a level 1 trauma center as your background noise.
It's a rhythm, isn't it?
It is. It's a rhythm you know well. And you also know the one word that can just completely shatter it: code. We all operate in these pressure cookers. It could be a STEMI, a stroke, a trauma. The stakes are always, well, they're existential.
Right.
And you, listening to this, you're highly educated. You already know the ACLS algorithms, the pathways. You could probably draw the PEA pathway in your sleep.
Oh, for sure.
So the goal for us today isn't to lecture you on clinical minutia. It's not about the precise milligram of a drug.
No.
Our mission is to talk about that gap, that terrifying high-stakes gap between the simulation lab and the reality of the trauma bay floor. We're focused on improving practice by mastering the psychological demands,
The mental game.
the mental game that determines not just the patient's outcome, but, and this is critical, your long-term survival in this job.
Yeah.
We really need to talk about what happens inside of you. Exactly.
And that conversation, it has to start immediately with the provider's physiology. So what we call the physiology of the provider.
Yeah.
The second that scream, "I need help,"
Right.
rings out, your body. It doesn't pause to access your nursing degree.
Oh.
It just initiates this primal ancient protocol.
It's that immediate, visceral fight-or-flight response, and you feel it instantly, don't you?
Instantly. That sudden, unwanted surge of adrenaline.
Yeah.
It causes these predictable and frankly detrimental effects in a clinical setting. Your heart rate is spiking, or sometimes, weirdly, it just drops to the floor.
Total shock.
Total shock.
Yeah.
Your peripheral vision narrows, that tunnel vision we talk about,
Yeah.
and your fine motor skills,
Yeah.
the ones you need to push a syringe or spike a bag.
Gone. They just evaporate.
Keep going.
It's a fascinating, but I mean a terrible biological trade-off. That response was designed to help you run from a saber-toothed tiger.
Right.
It was never meant to help you calculate the precise timing for an epinephrine interval while someone is, actively dying on your table.
Exactly. We're asking an ancient survival mechanism to perform these modern, highly calculated, precise tasks. And that transition, moving from raw instinct to precision, that's the core challenge for every single one of us.
And it doesn't matter if you're a new grad or a 20-year veteran.
Not at all.
Yeah.
The source material we're looking at, sure, it targets the novice, but that psychological truth applies to everyone. Managing that switch from internal chaos to external control, that's what we have to master.
So this entire discussion is really about survival, plain and simple. It's not just the patient's, it's yours. Because if you don't manage that internal shock, you risk drowning right there in the moment.
Or worse.
Or worse, you drown later in the cumulative trauma of it all. We're fighting to preserve your humanity and, honestly, your longevity in this field.
So if we accept that the chaos is inevitable, and in a level 1 ER, believe me, it is, then preparation is everything.
Yeah.
Our sources really emphasize that the most critical moment, it often isn't the first compression. It's the 10 seconds you spend walking from the nursing station to the trauma bay door. That short walk, that's your last chance for what we call self-triage.
And if you're lucky enough to get a few minutes notice, like EMS calls in a VFib arrest a minute out, or a rapid response is called just before they arrest, you have to use that time ruthlessly.
Time is your most precious asset there.
It's your chance to set up your laboratory. We're talking about, modern alchemy at its finest, transforming potential death into life with just some basic supplies.
So what are you grabbing?
You're grabbing the core tools, the 3 non-negotiables we need right away. First, epinephrine, obviously, the primary pressor. Second, AMEO, that's AMIO, the rhythm stabilizer.
The heavy artillery.
The heavy artillery, exactly. And critically, bicarb. You need that sodium bicarbonate ready for when that profound metabolic acidosis hits.
You get those 3 things lined up, your flush is prepped, lines cleared, your mind is already ahead of the game. You've eliminated those first frantic searches.
You've outsourced some of that cognitive load to your physical prep. But I want to pause here because there's a core mental health concept we have to stress. Before you crack that drug box, before you check the crash cart, you have to check your own pulse first.
And that's not an allegory, it's a clinical reality. If you walk into that room with your heart rate already at 140, just driven by your own unmanaged adrenaline, you're not just less effective.
You're actively adding to the chaos.
You are. You're adding to the environmental noise, the stress level of the whole room. Your unmanaged internal state makes you a consumer of team energy, not a provider of calm focus. You become part of the problem before the code is even really started.
Okay, so how do we fix that? How do we fix our internal state? We lean on an evidence-based technique for cognitive control that every single nurse needs to just internalize. Tactical or box breathing. The 4-4-4 technique.
We have to stop seeing this as some, like, wellness trend you do on a yoga mat.
Yes.
This is a mandatory life-saving intervention for the provider in a high-acuity environment.
Let's detail the steps, because the precision is what makes it work. You inhale slowly, deeply for 4 seconds. You hold that breath firmly for 4 seconds, and then you exhale slowly, fully for 4 seconds.
And you repeat it.
You repeat that sequence until you feel that shift. I mean, even 2 cycles can make a noticeable difference.
And the mechanism here is what's so important for an educated audience like ours. When you consciously control your breath, especially prolonging that exhale, you are forcing the engagement of the vagus nerve.
Right, the direct line to the parasympathetic nervous system.
The rest and digest system. You are literally hitting the chemical brakes on that runaway fight-or-flight response.
This action, it literally widens your cognitive bandwidth. It's the physiological difference between, like you said, primal panic and calculated, rational analysis.
It is. When you slow your heart rate and manage your oxygen, you improve cortical function. You absolutely cannot organize the chaos in that room. You can't lead a team. You can't remember those algorithms if your own internal state is already spinning out of control.
The 4-4-4 technique is your emergency override button. It takes you from a deer in headlights to a functional, effective team member. This is just, it's non-negotiable mental prep. Now, I want you to just think about this for a second. What is your go-to ritual beyond just grabbing the EP that brings you back to baseline before you walk through that door? Do you use 4-4-4, or have you found something else that works for you? Brief pause.
Whatever that ritual is, it needs to be concrete, repeatable, and fast. Because once you step across that threshold, the time for self-triage is over. You're now part of the machine, and your internal state has to be one of calm, directed energy. So once that mental prep is done, we shift immediately from self-triage to team structure. You have to stop thinking of a code blue as this random scattering of people yelling,
Right,
and start seeing it as a high-performance pit crew, like in NASCAR.
Yeah.
Everyone knows their job, and everyone just falls into line without being told.
At a racetrack, nobody's standing around asking, so what should I do now? They stake their claim instantly. And in the ER, okay, roles aren't always explicitly pre-assigned. We don't wear color-coded vests for airway or meds.
No, but the expectation is that stats stake a claim, and they do it quickly, based on the immediate need and their own comfort level and skill set.
And that structure needs a clear leader, which brings up the first and really the only necessary question to ask when you walk in that room, no matter your experience level.
What do you need?
What do you need? This question is so crucial because it helps you identify the code lead. That's step 1.
And defining that leadership role immediately converts you from a liability, a potential obstacle, to an immediate asset waiting for instruction.
And most likely that's the attending or the resident. But in some settings, it could be the ICU charge nurse or the most experienced nurse there. But asking that question clarifies everything.
And for newer nurses, or even experienced ones on a rough day, our sources highlight 3 tasks that are incredibly high value, but very low ambiguity. These are the roles you can default to, where you contribute immediately without needing to command the algorithms.
Okay, first, the compressor. We all know, high-quality chest compressions are the single most important intervention. We're talking 100 to 120 beats per minute, minimal interruptions, getting that depth.
It takes tremendous physical stamina, which makes it the perfect role for the nurse who is just feeling that initial wave of high anxiety and adrenaline.
If you have that rush of physical energy coursing through you, this is the most productive way to channel it.
Absolutely. It's a physical, rhythmic activity that forces you to focus. And you have to focus on using your entire upper body weight, not just your arms, leveraging your core.
When you do it right, you'll deliver compressions that are incredibly effective, often better than a mechanical device, at least in the first few minutes.
Right, better than even a Lucas device initially.
Okay, wait, I need to challenge that for a second. We use the Lucas devices a lot, and we know human compressors get tired after 2 minutes, right? The quality degrades fast. So, is it really fair to say a person can reliably beat a machine designed for perfect rhythm?
It is controversial, and it's all about context.
Mm-hmm.
The Lucas is brilliant for transport, for consistency during long codes, absolutely. But our sources highlight that a really focused human compressor, especially one channeling that initial adrenaline, can get superior depth and rate consistency in the beginning. The key is that rapid rotation every 2 minutes. before fatigue sets in.
So for the anxious provider, it's about a physical, beneficial task where they can use that high energy constructively.
Exactly. Instead of letting it manifest as, a tremor or panic.
Okay, that makes sense. So second role, the recorder scribe.
This is such an invaluable learning opportunity. You're at the computer, you're documenting every detail, every drug, every rhythm change. You are literally watching the algorithm unfold in real time.
But you're not just passively typing. You are the team's internal clock. You're their memory. You're actively calling out time intervals with authority. 2 minutes since last EP. Or pulse check in 30 seconds. You keep the leader grounded.
And trust me, you will only hesitate once on a dosing interval like forgetting if the next ambio is 300 or 150 before the stakes just imprint that sequence onto your brain forever.
It's learning by immediate, intense application, not by reading a textbook.
Exactly. And third is the runner, or the gopher. And let's just kill the stigma on that right now. This is not an inglorious job.
No. If the trauma bay is saturated with hands, you step out and you become the anticipatory resource manager for the entire system.
The runner is the person who keeps the code running smoothly from the outside. Your ability to anticipate needs more flushes, extra EP, blood gas results, finding the glucometer, grabbing a tube. It's a life-saving skill.
In a level 1 center, the team cannot stop to hunt for supplies. You can't pull someone from the bedside when compressions are happening. The runner prevents friction and keeps the whole system moving.
Which brings us to the behavior we absolutely must critique and eliminate.
The hazard of hovering.
This is, genuinely, the most dangerous behavior for a new nurse to engage in. Or any staff member, frankly.
It is lethal to the flow. It creates physical friction. If you are standing near the bed without a continuous assigned task, you are creating noise, you're blocking the team leader's line of sight, and you are physically obstructing people who do have a role.
Let's picture it. The doc is trying to get a femoral line, or the airway expert needs clear access to the head of the bed. A hovering body in the way causes these micro delays.
And those micro delays degrade the compression fraction. Imagine if someone hovering blocked the path for the nurse trying to swing the defibrillator over the bed. Even a 2-second delay can be critical.
You might be thinking, but I'm learning. And yes, every code is a learning experience, but there is a hard line between learning quietly and actively holding the operation back.
The sources are firm on this. If you don't have a role that requires continuous hands-on action, you have to find one outside that room.
Go check on the rest of the department. Go prepare for the next patient. Because the rest of the world, unfortunately, it does not stop for the code. Get your head out of that trauma bay and make sure your other patients aren't sinking while you're focused on this one. Your responsibility is bigger than just that one room. So once the roles are established, we have to focus on the mechanics of efficacy. Like we said earlier, effective resuscitation it's physics and chemistry. It's not magic. It's not luck. You are fighting natural decay with calculated force.
And nothing embodies that physics more than the compression fraction, the CF. This isn't just a metric for a QA report. It is life itself. It's the percentage of time during the code that compressions are actually happening.
And it has to be above 80%. Ideally, you're pushing 90.
Let's really dig into the physics of why this is so critical. Every single time hands come off that chest, even for a second, the coronary perfusion pressure, CPP, it drops instantly to near zero.
And CPP is the pressure differential that forces blood into the coronary arteries. It's what feeds oxygen and glucose to the heart muscle itself.
Think about that. It takes several compressions, like 5 to 10 seconds of continuous, high-quality pumping, just to build that pressure back up to a level that can perfuse the heart muscle. If you're constantly pausing, you're constantly restarting that uphill climb.
You never achieve adequate CTP.
Constant CPP is what sustains the heart. It's what makes sure the myocardium has the energy to twitch and eventually start working again. And that directly translates to sustained cerebral blood flow.
And that's the key. It doesn't matter if you get ROSC, return of spontaneous circulation. If the heart muscle and the brain tissue are not recoverable because of minutes of interrupted blood flow, the quality of the compressions dictates the quality of the return.
This is a crucial clinical pearl that everyone in that room, no matter their role, has to internalize. Do not pause compressions for intubation unless the code lead specifically tells you to for a brief visualization. Do not pause for vascular access.
Not for a peripheral line, not for placing an IO drill, not for attempting central access.
The only acceptable pauses are for rhythm checks, and those must be limited to less than 10 seconds. That is a hard evidence-based limit.
And for the actual delivery of a shock, which should be as fast as humanly possible, if you're the person doing compressions, you have to resist the urge to stop for anything other than a True timed pulse check.
The entire culture of the room has to enforce this. The scribe should be calling out if a pause exceeds 5 seconds. The physics demands continuity. The life hinges on it.
Okay, so moving from physics to organization, we have to talk about communication, especially in a noisy ER where auditory exclusion is a real thing.
Oh, it's so real. You've got alarms, people yelling, monitors beeping. It's sensory overload, and that is why closed-loop communication is not just a polite request. It is an essential survival strategy.
Auditory exclusion means that in high-stress environments, your brain just naturally filters out sounds it thinks are non-essential. It's helpful for focus, but it's lethal for teamwork if a critical order is missed or misheard.
Closed-loop communication, it doesn't just inform. It organizes the chaos. It makes every action actionable, verifiable, and safe.
It is the single core defense against medication errors and critical missteps. We're using repetition as a confirmation system under duress.
Let's run through the detailed script example because practicing this verbal ritual is as important as practicing compressions.
Okay. The leader gives the order, clearly. Give 1 milligram epinephrine IV push.
The med nurse repeats the order back exactly, confirmation. 1 milligram epinephrine IV push, confirming 1 milligram. Then they give the drug.
And then, and this is the most often misstep, they must close the loop by stating completion. 1 milligram epinephrine is in. Time marked.
That loop confirms 3 critical pieces of information for the whole room. The order was heard correctly, the dose was verified, and the action was completed and timed. This is crucial for the scribe to mark the time and for the leader to know exactly where they are in the algorithm. This simple, repetitive structure is what keeps the team grounded and safe when the environment is hostile and loud.
We spent most of our time on the mechanics of the event, but we need to transition now to the minutes and the hours and the days that follow. Because the event is absolutely not over when the patient transfers to ICU or when time of death is called.
No.
This is the moment of the crash, and it is a significant psychological hazard, especially for our newer staff.
That immense rush of adrenaline and cortisol that powered you through all that, it's not sustainable. It is going to drop you off a cliff. It's a genuine physiological and emotional collapse. For new grads especially, or anyone who really internalizes the intensity, the minutes after a code, even a successful one, can be profoundly unsettling.
Crashing is the expected physiological default if you haven't already prepared your parachute. We know of so many highly capable nurses who've been derailed after their first intense code, just struggling with intrusive thoughts, inability to sleep, self-doubt.
We have to be cognizant of this danger and proactively manage it. We need to intentionally interrupt that crash. Remember that 4-4-4 breathing technique we talked about for the pre-code pause?
You have to do it again.
You have to do it again. Step out of the room, find a quiet corner, the med room, a hallway, wherever, and do it again. This time with your eyes closed, just focusing on clearing your head and feeling that physical descent from that hyper-aroused state.
And this relates directly to trauma and internalization. Every nurse is different, and every code has different triggers. Maybe the patient reminded you of a loved one. Maybe the sound of the family crying was too specific.
Or the violence of it, the broken ribs, the blood.
Right. You might not even recognize the trigger yet, but the trauma is still processed. And the danger is that it doesn't just disappear after one shift. It builds, it accumulates code after code until it spills over.
That cumulative trauma is what leads to clinical detachment, to depersonalization, profound burnout, and eventually PTSD.
We have to look for the signs of it in ourselves and our peers. Increased irritability, emotional numbing, cynicism, difficulty concentrating. These aren't signs of weakness. They're signs that your neurological system is overloaded.
And we need organizational structures to prevent that from becoming career-ending. This is why mandatory clinical debriefing must be standard practice in high-acuity ERs. This is not optional.
It's a 5-minute standing meeting. Immediately after the patient has left the room or care is concluded, the whole team, nurses, docs, techs, respiratory, everyone should be there.
And the crucial goal of this immediate debriefing is non-negotiable. It is to identify systems issues. Period.
It is absolutely not the time to assign blame or guilt, especially since everyone in the room is already battling an internal tide of self-doubt and adrenaline crash. We have to create a space that is safe for learning.
Okay, I have to play devil's advocate here for a second. Doesn't focusing purely on systems let individuals off the hook when a clear, simple error was made? A misplaced drug, a miscommunication. How do we balance accountability with that vulnerability?
That's a profoundly important question, and it's about timing and culture. The immediate postcode debrief is purely psychological and systems-focused. If a clear individual error happened, that should be noted for a later, focused clinical discussion, usually in a QA setting, not in front of the entire exhausted team.
So the priority in those first 5 minutes is psychological and operational safety.
Exactly. The structure should be clear and non-judgmental. We start with the positive. What went well? We're looking for things like good role assignment, high compression fraction, great closed-loop communication. This reinforces positive behavior right away.
Then we move to what can we improve? Again, focusing on the machine, not the person.
Yeah.
There was a delay getting the IO drill tip, or too much noise in the room, or we have to reduce the time between compressions on pulse checks. The emphasis is always on the system.
And we need a direct confrontation with that old, stiff upper lip culture that has plagued nursing for so long. That outdated expectation that you just shrug it off.
Yeah.
It contributes directly to burnout and PTSD. It shortens careers. When a junior nurse is clearly shaken, leaders have to be the rocks they stand on.
Acknowledging that a traumatic code was difficult isn't a sign of weakness. It's a sign of profound humanity, and we have to protect that humanity at all costs. The minute you lose that, you've lost the core of why you're a nurse.
So we need concrete, immediate steps for emotional hygiene. Don't just leave the trauma bay in a cloud of chaos. Find your stethoscope, your tools, reground yourself in the reality of your trade. Get the peroxide wipes and clean up your personal area. Chug a bottle of water. Put the carts away. Just stop for a minute and breathe. Use that 4-4-4 technique.
You can't be useful to anyone else if you're broken inside. This tidiness, this regrounding ritual, it's self-preservation. Now, let me ask you, the listener, to reflect. How has your department's culture around emotional hygiene changed? Are we doing enough to protect the newest members of our team? Are we truly making it safe for someone to say, that one was tough, without feeling judged? Brief pause.
The culture of psychological safety in the ER is just as important as the culture of clinical safety. They're intrinsically linked.
So if the outcome was successful, the aftermath is about stabilization and transfer. But if death won out, we move into the final, sacred, and often rushed phase, honoring the patient's life.
And our sources really emphasize that a rapid disconnection from the situation, from your feelings, it's unfair to the deceased, and it is profoundly damaging to you.
This is the moment of respect. After the official time of death is called, after the physicians step away, the team needs to take a deliberate moment of quiet. Regardless of your beliefs, this is about respect for the humanity of the person who just passed. This body lying on that hard table was someone's mother, father, child.
This moment is a necessary transition point for us, the caregivers. We're moving from fighting so desperately, so violently for life, to honoring death and restoring dignity. It's a token of respect, and it provides psychological closure for the staff who poured everything they had into that fight.
And for our most experienced nurses, we need to offer a serious warning here from the sources. If you ever lose that feeling of being humbled by the harrowing effects of death, if confirming a death ever becomes just another task, you need to reach out for more support.
That loss of feeling is a major indicator that trauma accumulation is severely impacting you. We have to guard fiercely against becoming numb to human suffering and loss.
We then have to transition to preparing the environment for grieving loved ones. We call this phase in reverence. In a level 1 trauma center, there's often a high chance the family is on their way or already here.
And we have to give respect to the people who are about to step into the worst day of their lives.
Central to this is managing the visual trauma. We have to acknowledge the physical brutality of modern resuscitation. For a family, seeing their loved one after an hour of CPR and shocks can be shocking and offensive if they aren't prepared for it.
As providers, we know those measures. The broken ribs, the burns from the pads, the tubes, are brutally necessary. If possible, a provider should communicate that to the family before they view the body. But the nurse's job is paramount. Preparing the scene so the family can focus on the person, not the procedure.
This is where we show profound respect through our actions. We're treating the body with the same reverence we would want for our own loved one. The cleanup and preparation process is sacred work.
And we need to detail this process. First, remove attached equipment. Everything that's external, the lines, the tubes, the IOs, the wires, the pads, should be removed, as long as it doesn't interfere with the coroner. Don't just cut them. Remove them gently.
Then, clean the immediate area thoroughly. The table, the computer stand, the floor. Get the bicarb and EP caps out of the sink. Critically, clean up any stains on the floor, even old ones. Get rid of the trash, the dirty linen. Make the room neat.
But the personal care is paramount. This is the act of restoring dignity. If you can, sit the person up gently. Wash their face and hands, cleaning away any evidence of the code. Put on a new gown, a fresh one, covering the chest injuries. Place a clean sheet over them, get a clean blanket. We are restoring their physical presentation after we have physically assaulted their body to save their life.
You are giving the family a brief, dignified moment of peace to say goodbye without the overwhelming visual trauma of the procedure.
And for the newer nurse, an important piece of advice. This might not be the time for you to follow the provider out to speak with the grieving family. Holding space for that raw grief requires immense emotional preparation.
Being that rock-steady nurse they need, it takes practice. That skill will come in time, and you should never feel pressured to rush into that until you're truly ready to hold space for their grief without breaking yourself. Focus on the dignity of the cleanup first.
Ultimately, the source material reminds us that we have to be intensely cognizant of ourselves before, during, and after every single code. We have to stay prepared, we have to stay vocal, and we have to stay humble, no matter the outcome.
This entire framework is designed so that the next code you run, you'll be slightly more confident, ready to take on a new role, and better equipped to survive the experience intact.
So let's leave you with a powerful list of contrasts. A final safety checklist for professional integrity and personal health.
Don't panic. Breathe. 4-4-4.
Don't assume. Communicate. Closed loop.
Don't take flight. Stay and fight. Compression fraction.
Don't forget to respect the situation, the person, and their loved ones. Tribute and reverence.
And crucially, don't disconnect. Debrief. Emotional hygiene.
Remember why you trained for this. This work, this intensity, this calculated effort to restore life is the absolute pinnacle of your skill and your profession. There is truly no greater honor than using all the skills and knowledge you possess to fight for someone who has entrusted their life to you.
And building on that point, that we must focus on systems improvement during debriefing, we want to leave you with one final thought to consider for your practice and your facility's culture. If our standard clinical debriefing is focused only on identifying systems issues and clinical performance, how can we better integrate a formal, brief, and mandatory mental health check-in entirely separate from the clinical discussion into the post-code ritual to ensure that no one, especially our newest staff, leaves the warm broken? That is the next challenge for us as educators and as leaders in emergency medicine.